Good afternoon, and thank you for joining today's webinar, Break the STI Cycle with Accurate MGen Testing, hosted by Hologic. My name is Susan Hepworth, and I will be facilitating today's webinar. I am pleased to be joined by Dr. Jamie Shutter, Senior Vice President of Lab Development at Unified Women's Healthcare. And also with us today is Dr. Melissa Maxwell-Stropes, Senior Manager of the Medical Science Liaison Team at Hologic. Dr. Shutter and Dr. Stropes will be presenting on today's webinar. After my brief introductory remarks, I will turn it over to Dr. Shutter, who will give his presentation. And then following Dr. Shutter's remarks, we will turn it over to Dr. Melissa Maxwell-Stropes. After her remarks, we have reserved time at the end for question and answer. And then upon conclusion of the question and answer, the webinar will conclude. As mentioned, we have reserved time at the end just for question and answer. And so the easiest way for you to put your question into the queue is at the bottom of your screen. You will see a Q&A box down there. Go ahead and feel free to put your question into that box at any point during today's webinar. There's no need to hold your questions until the end. As they come to your mind, go ahead and type those in, and I will get those added to the question queue. You can also talk to us via the chat box if you have any other sort of questions, comments, or concerns. And with that, I will go ahead and turn it over to Dr. Shutter.
Hey everyone, thank you so much for the introduction. I appreciate those of you that have joined us online. From what I've been told from all over the world. Just a little bit about myself. I am a GYN pathologist. I have been doing lab development in the women's health space now for over 10 years, and currently am laboratory director of 3 women's health laboratories around the country. I'm also, as mentioned before, Senior Vice President of Laboratory Development for my overarching company, Unified Women's Healthcare. I also did a clinical year of OBGYN prior to going into pathology, and then did a fellowship in GYN breast pathology, and have extensive background in GYN pathology. Today, I'll be talking about MGen, which has gained a lot of attention in the literature and has been recognized by the CDC. But it's still an organism many physicians don't know about and the laboratories don't yet test for commonly. And it's as they do with more well-known sexually transmitted infections that we typically think of, like gonorrhea, chlamydia, and trich. So I wanted to start out by just the importance of STI surveillance. STDs reached an all-time high in 2019. And there's actually some new data that came out very recently within the last couple of days that looked at some additional time periods that we are going to be going through at a later date to see if these are continuing to rise. And as you can see, chlamydia has gone up 19% since 2015, gonorrhea 56% since 2015, and syphilis 74% since 2015. And then syphilis among newborns, which is obviously significant, is almost 300% since 2015. Anyone who has sex obviously get an STI, but some groups are more affected. As we know, those young aged people in the 15 to 24-year-olds are extremely at risk. Gay and bisexual men, pregnant people, and then racial and ethnic minority groups that are also disproportionately affected. So the first thing we're going to talk about is persistent or recurring cervicitis. The definition of that, for those that are not aware, is cervicitis that persists after treatment when re-exposure did not occur. This is frequently asymptomatic and commonly caused by the things you're commonly aware of, like gonorrhea, chlamydia, trich. HSV2 can obviously also cause this. And then, MGen, which some of you may not be as aware as you are the other STIs. Diagnostic criteria include purulent or mucopurulent endocervical discharge, visible in endocervical canal, or an endocervical swab specimen. The pictures on the right side of the screen show a swab with mucopurulent discharge, and believe it or not, the picture next to it, that's a cervix with mucopurulent discharge on top of it. and the discharge is even covering the cervical os. So it's really difficult to even visualize the cervix at all in this particular picture. Signs of inflammation, such as sustained endocervical bleeding easily when induced by genital patches of a cotton swab through the cervical os. So if you are a clinician on the call and you are getting easy bleeding when you're doing an endocervical sampling, that is also another indication of potential cervicitis. The inflammatory component that occupies the mucosal lining will it'll break down the endocervical lining, and therefore it's going to be much easier to bleed when a swab is passed through. Most persistent cases of cervicitis are not caused by reinfection with gonorrhea and chlamydia. Rather, other factors might be involved. And I think one of the things we're really thinking about, going forward is that MGen could be significantly involved in some of these reinfections. This is actually my favorite slide of the presentation because it goes over both the clinical and the pathology behind a lot of this. Having done a year of clinical at Johns Hopkins, and this is also back before the work hours restrictions, it was the 120-hour work weeks and 36-hour shifts every other day. It was interesting and difficult. So I'm going to go over pelvic inflammatory disease. Can be difficult to diagnose because there can be subtle or non-specific symptoms. They're commonly caused by STIs such as gonorrhea and chlamydia, as we all know about, but there have been associations by multiple studies with TRIC and MGen. We haven't got, unfortunately, them being definitive causes, but the associations are routinely statistically significant. The diagnostic criteria for the diagnosis of PID, you need to have at least one of the three present: cervical motion tenderness, uterine tenderness, and adnexal tenderness. This just gives you an idea the patient may have PID. Cervical motion tenderness to me is the most significant of these. And I have a great story from my days doing emergency room consults at Hopkins, when we'd have the emergency medicine people call us down when they said the patient had cervical motion tenderness. And cervical motion tenderness is a sign of peritoneal inflammation. And a lot of times, if you don't distract the patient, they're going to be very uncomfortable when you start wiggling their cervix. Because what you do actually is you put two fingers on both sides of the cervix and you move it back and forth, which should cause the peritoneum to stretch. And if there is inflammation in the peritoneum, they become extremely agitated, and it's very painful. And they actually call that, I don't know how many are familiar with it, called the chandelier sign. Because if you do it the right way, they'll actually technically should jump for and try to hang on to the chandelier. That's how painful it is. And so I'd go down to these consults, and the emergency room doctor would tell me that the patient has cervical motion tenderness. I would do the exam and I would just kind of chat with them while I'm doing it, and not let them know what I'm doing. And I move their cervix back and forth, and they don't even move. So you could tell that they don't have peritoneal inflammation when that happens. So otherwise, like I said, they usually will jump for the chandelier or the ceiling. So really interesting stuff. And interestingly, up to 22% of women with PID have MGen. Now, unfortunately, we don't have a lot of good studies studies at this point showing that MGen is a cause. However, there are studies with animal and in vitro studies as well that show that MGen is shown to cause not only endocervical damage, but also tubal damage as well. And therefore, the tubal damage, as you can see from this schematic here, if you look to the right, you see microscopic image of a normal fallopian tube lining with the fimbriated areas kind of wiggling in the wind and all that sort of stuff. And then the one on the left is after PID or any sort of, insult to the fallopian tube villi. They become clubbed or scarred, and therefore the egg is not easily able to pass. You'll get kinking of the tube, and that could lead to a lot of different clinical consequences. PID in general, due to tubal damage, can lead to infertility, ectopic pregnancy, and tubo-ovarian abscesses. I can also give you some anecdotal stories, of having to do life-saving surgeries in patients that came in with ruptured ectopics, where the patient had a history of PID and tubal scarring, and trying to save the life of a 25-year-old woman with an ectopic pregnancy. when people start dying, healthy women start dying at the age of 25, that's usually a pretty difficult thing. So, really, these can be really life-saving procedures. And if we identify MGen as another potential cause of PID and preventing that from happening, we could, hopefully prevent maternal morbidity and mortality when it comes to ectopic pregnancy. Other thing is the formation of tubo-ovarian abscesses. And, generally we try to treat these patients with heavy antibiotic therapy before trying to go in there and do a laparoscopic procedure potentially to remove any sort of residual tissue, because there's a big chance of rupturing these and having it spill, all the pus spill into the peritoneal cavity, which I don't think I have to explain to you the consequences of that. But ones that are already ruptured, or ones that we feel like we could have removed and the symptoms were so significant that antibiotic therapy may not have been the first choice, we did go in and actually try to remove them. And I've seen some surgeons by accident puncture them and therefore have it spill all over the cavity. So again, there's so many clinical consequences to PID, and we still don't know enough about it. And I feel like with all these associations and the fact that up to 22% of women with PID have MGen, and with the animal and in vitro studies, there is a significant amount of research we can do into this to see if we can, by preventing ascending infection due to MGen, we may be able to reduce all of these things. Tubo-ovarian abscesses, ectopic pregnancies, infertility, which also cost a lot of money to the medical care system. So very interesting stuff. And I'm really hoping that we get some more literature out there in the short term to kind of look at, more than just association, but actual cause. The one study I do want to mention is a study from 2015, a bunch of Saudi women that compared removal of ectopic pregnancies to tubal ligation. And that showed actually a statistically significant association with MGen infection by nucleic acid amplification. And that's interesting because, ectopic pregnancy, again, is generally related to either bouts of PID or tubal scarring. And if we have a significant association between MGen infection by gnat, for instance, in those patients, whereas tubal ligation, there was no MGen infection, that's some pretty strong data. And so I think we're really moving towards the point of, really having a causative effect as opposed to an association. So I'm really excited about these animal and in vitro studies. Really much more difficult to do them on human subjects, just because of, how you would have to set these ones up. But, really exciting stuff coming in the future. So consider MGen. It's a prevalent, often misdiagnosed STI. It was first identified in male nonococcal urethritis cases in 1981. And there's a lot more literature out there on male urethritis with MGen. And unfortunately, there's just not as much with women. And so I'm hoping that will change as we move forward, especially with the CDC really focusing on MGen as a true pathogen, as they've re-indicated in the 2021 CDC guidelines. So they live on and in epithelial cells of the urinary and genital tracts. As I mentioned, they can cause, at least in vitro and in animal studies, endocervical damage as well as tubal damage. There's significant morbidity in both men and women, and it's a sexually transmitted infection, which I think a lot of people are not completely aware of. I think that especially when there's something new, understanding that it's not, that it is sexually transmitted, I think is extremely important when it comes to partner treatment. And we can talk a little about that more later on. So why are we only hearing about this now? Like, this seems like a big deal, right? I mean, why have all of a sudden has this become such a big topic now? Well, clinicians in the early 70s were finding that non-gonococcal urethritis can be treated with antibiotics, but do not observe bacteria in the urethra. And we weren't even be able to successfully culture this until 1980. And then we moved all the way from 1980 to 2015, when the CDC actually, in their 2015 guidelines, which are the ones that came out before the 2021 guidelines, recognized MGen as an emerging infection and recommended NAT testing for MGen. In 2019, Hologic came out with the first FDA cleared NAT testing for MGen. And so before that, it was very difficult to identify this pathogen. And then in 2021, it kind of went from emerging pathogen to specifically recommending testing in specific testing populations for MGen. And we'll talk in a later slide what those specific populations are. So clinical presentation can be non-specific. It's very similar to other STIs. And I will show in a later slide how many overlapping symptoms there are. So it's very difficult to differentiate these clinically. Microscopy, it cannot be seen on microscopy because generally what we do when we stain these sorts of organisms and organisms in general is we stain the cell wall. Because it doesn't have a cell wall, you can't really see it under the microscope due to the cell wall will not uptake the stain. Culture is not clinically feasible as it may take up to 6 months. And obviously, telling the doctor or a provider that you can do the culture, but we'll give you an answer in 6 months is not something they're really going to want to hear. And anybody would really want to hear. Or a lab would, sort of have a way to do something like that that's clinically meaningful. So nucleic acid amplification testing, or NAT testing, is the recommended method of detection. And luckily, we now have a test that we can do. And Dr. Melissa Maxwell-Stropes will talk more about the logistics of testing later in the talk. Okay, so right now I'm going to take a deeper dive into the clinical presentation of MGen and highlight some of the challenges when attempting to diagnose a patient based solely on presentation of symptoms, because again, there's such overlapping symptoms. So this slide, I think, is pretty powerful. It's showing you the main symptoms you see with STIs, abnormal discharge, vaginal odor, vaginal irritation, pain during urination or sex. And it's showing you on the other axis, trick, BV not really being sexually transmitted, yeast infection, same thing, chlamydia, gonorrhea, and MGen. And you can see that discharge, vaginal discharge, is a sign of all of these. Vaginal irritation is a sign of all of these. And then the other two, are more specific to others, but these large overlap in clinical symptoms, I think is one of the things that makes it really difficult to clinically diagnose this, considering also we can't do any sort of in-office microscopy to identify it. And the prevalence is about 10%, but I'm going to talk about the prevalence later as I kind of dive more into prevalence in general. So MGen can lead to health consequences for females. It's detected in 10 to 30% of women with clinical cervicitis. It's identified in up to 22% of pelvic inflammatory disease cases from that slide I showed you earlier, which was my favorite slide, with getting all my stories from my internship in OBGYN. Persons less than 34 years of age are most likely to be affected by MGen. And we'll talk about this with specific between men and women in later slides. There's also a twofold increase risk of cervicitis, PID, infertility, and adverse pregnancy outcomes with MGen infection. Now, it doesn't mean that there's a cause, but there is a twofold increased risk of having these if you have MGen infection. The two main adverse pregnancy outcomes that I'm referring to here are preterm birth and spontaneous abortion, which definitely needs more research. But again, these are obviously things that we want to try to prevent. And so identifying potentially that MGen is not only associated, but a cause of some of these things can really help us potentially lower these adverse clinical pregnancy outcomes. So I'm going to talk about men for a little bit. There are clinical consequences and a lot more data actually on men, because this was kind of studied a lot earlier than it was in women. It's more likely to also exhibit symptoms of MGen infection. So if you take a population of men and a population of women that are all affected by MGen, the men are more likely going to be showing symptoms. And it's actually responsible for 40% of persistent or recurrent urethritis in men. And 73% of those MGen positive men show signs of urethritis, which is obviously fairly high. MGen also is present in up to 25% of men with acute non-gonococcal urethritis and over 33% of men with non-chlamydial non-gonococcal urethritis. So there is significant clinical consequences with men as well. Okay, so I'm going to talk about prevalence next. I kind of alluded to it a little bit earlier, but now that we understand the clinical presentation, and the negative health outcomes associated with MGen, let's kind of take a little bit of a deeper dive. Like, how big a problem is this? How much are we seeing this in the population? So I think it's a really interesting slide. This shows that, you know, the low risk populations versus the high risk populations, and you also have the female prevalence on the left and the male prevalence on the right. For low risk populations, they tend to be, for male and females, tend to be pretty low in the 1 to 3% range. But in your high risk populations, there's a huge difference between how you see it in women in like the 7 to 14%, whereas the range just goes up to 41% in high risk populations for men. And you can see on the left and the right the differences between these populations. Patients not attending an STI clinic would be considered low risk. Patients attending fertility clinics, patients randomly selected from otherwise healthy population. Whereas on the right side, you know, patients attending an STI clinic, which may be because they're concerned that they have one, would be high risk. Patients presenting to family planning clinics for termination of pregnancy. Obviously, if they have a termination of pregnancy, if they're considering that, they've had unprotected sex. Symptoms of urogenital disease in general, and then any people in the sex industry are also in that high risk group. One of our 3 current laboratories in our system actually does test for MGen routinely in our vaginitis panel. And our rate is 5.6%. Now, interestingly, in that same location, our chlamydia rate is 3.87 and our gonorrhea rate is 0.77. So in our experience in that one location, we actually have a higher rate of MGen than we do for gonorrhea and chlamydia combined. And if it does pan out that these are not just associations and that MGen is an actual cause of a lot of these clinical consequences, it could be a much bigger problem than even gonorrhea and chlamydia because of the higher prevalence. And just to give you another piece of data, in that same laboratory that we use MGen as part of our symptomatic vaginosis vaginitis panel, we also have our trick rate is about 3.36%. So even the trick rate is lower than the MGen rate. And that is just on those symptomatic patients. So our overall trick positivity is prevalence is lower when we add in some of the ones that are just being screened, because, you know, clinicians, depending on their, you know, how they decide to screen their population, will do gonorrhea and chlamydia and or trick. And so we do get those trick just for those that are looking to just screen their patients for STDs. And generally we don't, you know, there is no recommendation right now to add this in as a screening test, but, and we'll talk about the special populations that the CDC is recommending now. I just felt based on the data that was out there and with provider feedback from our doctors that this would be an important organism to identify since there is such a push to understand its pathogenesis and its association with symptoms, that we do treat these patients. And I really do like the fact that we're doing it in one of our locations currently. Some of this data may be diluted a little bit because I constantly have to try to remind providers that screening asymptomatic patients or patients that are pregnant for vaginosis and vaginitis is not clinically necessary. And even the CDC came out, you know, in their latest guidelines reaffirming that screening for asymptomatic BV in pregnancy has not been shown to prevent preterm birth or increase the rate of preterm birth. So just kind of reiterating that to our docs, I really feel our MGen rate on symptomatic patients is even probably higher than 5.6. Okay, so looking at the prevalence of MGen, first we're going to start with females. As you can see, it's very similar to other STIs where you have that kind of like less than 24, that 15 to 24 population, and it kind of really it's very similar to what we see in gonorrhea and chlamydia with women. Men, a little bit different, at least in the Getman study, which is the one in dark blue, you actually see a spike in the 21 to 30 But still, in general, the younger patients are more affected than older patients. So again, that's just letting you know that there are some differences between males and females, but in general, the younger you are, generally, the more at risk you are of being infected with MGen. Okay, so this year, the CDC weighed in on specific populations to be tested. And I wanted to highlight those now, as I alluded to earlier in the talk. And as I mentioned again before, 2021, the CDC came out with all their new guidelines. So any of you that haven't had a chance to read them, more specifically about other pathogens that we're not talking about today, or want to just hear more about MGen or read more about MGen, there's a lot of really good data in there. So it's a long document, but I've read it several times, and it's extremely, extremely valuable information. Okay, so these are the recommended MGen testing populations. Testing is recommended for women with recurrent cervicitis and should be considered in women with PID. And then testing is recommended for men with recurrent non-gonococcal urethritis. Now, even though these are the recommendations by the CDC, I think based on the data, that I did not hesitate to recommend to our doctors that we included MGen in our routine symptomatic vaginitis, vaginosis panel, just because of all the data out there and how the CDC had changed their tune from emerging infection to like real deal infection in 2021. And I think we've seen a lot of identification of this organism and proper treatment. And I think we're really, I'm really happy with how we decided to do that. Always like to be a pioneer, in the laboratory field, to really move forward and try to, treat our patients the best and most specific way we can. Without testing for MGen, that 5.6% of those symptomatic patients would have gone undiagnosed, and therefore, we wouldn't have known what antibiotic therapy to try to treat them with. So I think there's a lot of really good, value in that. Okay. So the next couple of slides, I kind of want to talk about the other mycoplasma and the ureaplasmas that are out there. There's a big myth that you need to have Mycoplasma genitalium, Mycoplasma hominis, and a 2 ureaplasma species. And if you look at multiple sources, including the CDC, they're saying don't. And I'll tell you why here. So first, this is from the International Union Against STIs. And it says that routine testing and treatment of asymptomatic or symptomatic men and women with Mycoplasma hominis or the 2 other major ureaplasmas are not recommended. So they have not yet been shown to be actual pathogens, and probably they're more commensal organisms. So treating these, or even trying to identify them, is kind of a burden to the medical care system. And then, as we're going to talk about later, the more you identify things that are not pathogenic and then try to treat them, you're just promoting more antimicrobial resistance and making it harder to treat the things that are actually real deal pathogens like MGen. Asymptomatic carriage of this bacteria is common, and a majority of these patients do not develop disease. Extensive testing, detection, and subsequent antimicrobial treatment says result in a substantial burden and economic cost, particularly in women. So it's really important that we don't attempt to identify these other organisms that are not shown to be pathogenic. And the second consequence is, if you do identify them, then you're treating them, so you're sort of doing a double no. So increased costs to the medical care system, promoting antimicrobial resistance. So I really recommend not testing for these, and therefore, if you're not testing for them, you're not going to be treating them and promoting antimicrobial resistance. Next is straight from the CDC, and they're actually recommending not to test for them. There's a couple quotes here from the CDC guidance from 2021. Data are inconsistent regarding other mycoplasma, meaning Mycoplasma hominis, and their ureaplasma species and etiologic agents of urethritis. This is regarding men. The majority of men with ureaplasma infection do not have or with disease unless a high organism load is present. So, just knowing whether ureaplasma is present in men may not be enough to say they are symptomatic or deserve to be treated. So, and right now the MGen, most of these ureaplasma assays that are laboratory developed tests are not looking at concentration, they're looking at a qualitative, is it present, is it not? And if you're treating all these patients that a little bit of ureaplasma may not affect them, whereas those very small proportions that have high microbial load, you're really potentially treating a lot more patients that need to be treated. So, and again, that's just really with men. Now, when it comes to cervicitis in women, testing for the 2 ureaplasma as well as Mycoplasma hominis is not recommended, like legit said, not recommended by the CDC. And again, backed up by our last slide with that international society on STI prevention. And again, no specific evidence exists for a role of these ureaplasmas in cervicitis. So I try to impress on all of our providers, and the providers that make up the 3 laboratories I currently direct. We have, I don't know, 6, 7, 8, close to 900 providers. And I try to do the best I can with trying to educate them on the latest data we have about these other organisms not being pathogenic, and therefore we should not be testing for them. Okay. So the CDC has also offered specific recommendations for treatment of MGen. We know that MGen is growing in antibiotic resistance. So the CDC has developed specific pathways depending on the availability of testing and testing with resistance susceptibilities. So here is a really good schematic on how to treat these patients. Now, unfortunately, most reference laboratories do not offer any sort of resistance testing. And I recently checked within the last week, both the 2 major reference laboratories, we all know who those are, and there are no tests on their laboratory test menu that test for resistance for MGen. So even though we have the macrolide sensitive on the left, because we can't tell if they're macrolide sensitive, we really have to rely on the algorithm on the right, which is the macrolide resistant. So that's doxy for 7 days, followed by moxifloxacin because of the high incidence of azithromycin antimicrobial resistance. So just really important to understand this algorithm because we don't have commercially available resistance testing currently, not saying there won't be something hopefully in the near future. We really need to stay on the right side of the treatment algorithm to make sure that we're not having patients that are not actually being completely cured of this disease. So the next slide just talks about the rates on the rise. And these are multiple clinical studies over a course of years, going from on the left side, 2016 to 2018 and 19, and 17 to 19. You can see that the antimicrobial resistance has continued to rise as years have gone on. And unfortunately, I also believe that treating of some of these other pathogens that are not actually pathogens is contributing to this antimicrobial resistance. So not even testing for these other ones is why it's part of the reason it's not recommended is because they're not pathogenic, and 2 is again that promotes additional antimicrobial resistance. Okay, so in 2019, I don't know how many of you are aware of this, but the CDC created this watch list to identify organisms that are not considered pathogens and only promote antibiotic resistance to macrolides. So the important point here is that we have several organisms on this list, okay? And MGen is one of them. So if we are, just like I said before, if we are treating things that are not pathogenic, we are promoting that. And this is already on the watch list for antimicrobial resistance. So this is a quote, again, from the CDC, that MGen bacteria are sexually transmitted and can cause urethritis in men and may cause cervicitis in women. Few antibiotics are available to treat, and resistance to erythromycin, which has been recommended for treatment, is high across the globe. So it's really, really important that we don't treat anything but MGen, because all you're doing is promoting additional macrolide resistance for MGen, and then causing potential harm to the patients that actually have MGen by not allowing the azithromycin to be able to be effective against it. So anyway, so that concludes my part of the talk. I want to thank you for all of your attention. As Susan pointed out, there will be a Q&A section after the next section of the presentation. And now I'm going to introduce it over to Melissa Maxwell-Stropes to talk about other aspects of MGen that I think are very important. So thank you very much for your attention.
All right, I'm going to take over. All right, can someone confirm that they can see me?
Yes, everything looks great.
All right, wonderful. So my name is Dr. Melissa Maxwell-Stropes. I am the Senior Manager of the Medical Science Liaison Team at Hologic. But prior to working at Hologic, I was the Technical Supervisor of a clinical molecular lab at a large community hospital system. And so as a former laboratorian myself, I want to thank everyone on this call for joining us and wish you all a happy early lab week. Dr. Shutter had mentioned in his talk a lot of aspects of MGen and some of the history. For my portion of the talk, I'll be discussing the optima mycoplasma genitalium assay itself, and I'll be talking about the clinical trial to start us off. And in the previous slides, we saw that MGen was first cultured in the 80s, but it wasn't until 2019 that there was an FDA approved or FDA cleared assay. And so certainly there were laboratories that might have been offering LDTs, and certainly there was a lot of studies and more research that went into MGen. But really, laboratories were really interested in having an FDA cleared option for testing for MGen. And because the evidence was accumulating for the symptoms and signs and associations with disease, we wanted to be able to provide that option. Now, the CDC has commented that they recommend NAT testing for MGen detection. And before I get into the clinical trial, I just wanted to level set briefly. I know we've all talked about molecular testing ad nauseum for the past couple of years, especially with the pandemic, but I just want to make sure that we are using the same terminology. So NAT stands for Nucleic Acid Amplification Testing. And in short, that's just taking a little bit of nucleic acid or genomic material and amplifying it a whole bunch for downstream detection. That's it. And sometimes people will interchange NAT testing with PCR. PCR certainly is a type of NAT, but it isn't the only type of NAT. In fact, the type of NAT that's being utilized by the optima mycoplasma genitalium assay is transcription-mediated amplification, or TMA. And I'm not going to talk too much about TMA, but I just wanted to mention that it is a way, again, to take a little bit of genomic material. In this case, it's 16S rRNA. And using RNA polymerase and reverse transcriptase, we take a little bit of that isolated material, we amplify it a whole lot for downstream detection. So this is really a robust way to, again, take a little bit of nucleic acids and see it at the very end. But I think it's important to understand both NAT testing, again, since it is the recommended method of detection, but also TMA to a little bit better understand our clinical trial. And so we talked about the fact that you can't really culture MGen well. Of course, it takes a really long time, and you can't stain it. So thinking about how to conduct a clinical trial and really how to get good data, it's really a challenging undertaking. But our R&D department rose to the challenge, and not only did we produce an optima mycoplasma genitalium assay that would later go on for commercial use, but they additionally created 3 alternative TMA RUO assays. And these targeted either a different region of 16S rRNA or 2 different regions in 23S rRNA. And these alternative TMA RUO assays allowed us to establish patient-infected status, which would ultimately allow us to determine analytical sensitivity and specificity for the optima mycoplasma genitalium assay, which is the one that's used commercially. And so with that design in mind, I wanted to talk briefly about the actual patient enrollment and the patient study. So our clinical trial was called the AIM study. It was the optima Mycoplasma genitalium assay evaluation study, and it was a multi-center prospective study which enrolled both men and women over the age of 14 years old who were sexually active, and they were either symptomatic or asymptomatic for a suspected STI. The enrollment sites included 21 different sites, and they ranged from OBGYN facilities to STI clinics and urology centers. But it was spread across 15 different states, including Washington, D.C. After some patients were excluded, we evaluated 3,300 patient samples. Now, roughly half of those were female and half of those were male. And from the female patients, we collected, or they had collected, first void urine, patient collected vaginal swab, clinician collected vaginal swab, and endocervical swabs. From males, they had collected clinician collected urethral samples, patient collected penile meatal samples, and first void urine. So among those men and women, there were 7 different specimen types collected for this study. So that's a tremendous amount of work. So the next act was to establish patient infected status. And the way that was done was by looking at reference swabs. For females, that reference swab was patient collected vaginal swab. And for males, it was male urethral swab. And patient infected status was established by taking those two of those 3 TMA RUO assays and using them to see what the actual status of the patient was. If they were both positive, then the patient was considered positive. If they were both negative, the patient was considered negative. If they disagreed, then the alt-TMA RUO assay was brought in for discordant resolution. And with that in mind, with patient infected status established, then the optima Mycoplasma genitalium assay was able to be tested in those particular patients. If patient infected status was positive and optima MGen was positive, then that was considered a true positive for that specimen. If patient infected status was negative and the specimen tested by optima Mycoplasma genitalium was considered negative, then that was a true negative. All in all, patient infected status was established for almost 12,000 patients. That was an incredible amount of work. This optima Mycoplasma genitalium was tested on 3 different panther sites, and all in all, over 35,000 tests were ran for this clinical trial. And so, of course, this is a tremendous amount of work. But again, as that clinical evidence keeps accumulating, as more research comes out, and as our laboratory partners were asking for a way to have an option for FDA-cleared MGen testing, it was absolutely necessary. Additionally, in the study, we also found a little bit of epidemiological information, some of which Dr. Shutter has touched on before. We found in the study that the prevalence was about 10% in both males and females. And also, like other STIs, MGen seems to skew younger. In the 15 to 24-year-old range, we found in our study that those women with in that age range were 5 times more likely to have MGen than in ages 35 to 49. Similarly, in men in that age group, they were twice as likely to have MGen than in that 35 to 49-year-old range. From an epidemiological perspective, Black men and Black women were more likely to or have a higher risk of infection. Also, women who had been previously diagnosed with vaginitis and men who had been previously diagnosed with urethritis were had a higher risk of infection as well. So after I described our clinical trial, I wanted to take a step back too and just talk a little bit about the detection of MGen sort of on an organismal level. Interestingly, with MGen, the bacterial load of MGen in comparison to other types of STIs it's actually pretty small. And this is a study from Frohlen et al. In which they looked at the median bacterial load of chlamydia and MGen in first void urine in men. And what they found was the median bacterial load for chlamydia was 42 times higher than that for MGen. So because MGen wasn't as abundant, it was really important that we made each of those organisms count. And so the way that happened was through the choice of target. We already talked about nucleic acid amplification testing, and certainly gnats can target DNA or RNA. In the case of optima mycoplasma genitalium, our target was ribosomal RNA. And the reason is that it's far more abundant in the organism than DNA. So our input in the reaction already is much higher than that of if we were starting with the DNA target. And what we found is that our RNA-based assays target 40% more, or identify 40% more patients than DNA-based tests. And this was shown in two different studies. The first study is the FAME study that came out of Bordeaux University in France. And so they looked at the optima mycoplasma genitalium assay. Again, that's an rRNA-based assay. And they compared it to a DNA-based LDT. And what they found is the optima rRNA-based assay identified 40% more positives than that of their LDT. Similarly, in a study that came out of the Nordic region, they looked at optima MGen, which again, rRNA-based assay. They had access to the alt-TMA #1 RUO assay, which again is ribosomal RNA, but it's just in a different region. And they compared it to their in-house qPCR DNA-based assay. And again, what they found is the rRNA-based assays were able to identify more positive patients than the DNA-based assays. And I also want to note that the specificity in these studies were very similar as well. So again, because the organism amount is so low in these particular samples, we really want to make them count. And so our RNA is an excellent target for that, just based on its abundance. So now that I've talked about a little bit about the clinical trial and how we conducted that and the patients and also the target in particular, a little bit about the biology, I just want to talk a little bit more about the use on the panther system. Again, the actual optima MGen assay is targets rRNA, and it uses transcription-mediated amplification. And many of you, while that term may not be super familiar to all of you, it's that same technology that's used in many of our other assays on the panther system, like Optima Combo 2, Optima HPV, and Optima Trick. Again, this was the first FDA-cleared gnat for detection of MGen. And the great part about it is it's run on the panther system. And so many of you are familiar with our expansive menu, and certainly Optima just adds another menu onto that, or another test onto that menu. Additionally, the panther has been well appreciated by laboratorians and physicians alike based on the collection device itself. I want to talk about collection a little bit more. In our clinical trial, we talked about the fact that there were 7 different specimens tested in the clinical trial. And this occurred on 3 different collection devices. The first is the Optima multi-test swab, which is the collection device with that orange sticker on the outside, and it comes with the pink swab itself. And that's used for clinician-collected vaginal, patient-collected vaginal, and patient-collected penile meatal swabs. The second is the Optima urine collection kit, and that's used to collect first void urine that's collected in a cup. And then the bulb pipette is used to transfer first void urine into that collection device. And that's for use with first void female urine and male urine. And lastly is the Optima unisex kit, which is the kit with the sort of white sticker on the outside and then that purple writing. It comes with a purplish blue swab. And that's used to collect endocervical and also male urethral samples. So there's 3 different collection devices for these 7 different sample types. And what's nice is that the physician can really sort of mix and match and figure out which one makes the most sense for his particular patient or her particular patient in that setting. And maybe there's additional testing that might be done from that sample, or maybe it's just a convenience factor, but there's a lot more options. And of course, no matter what the specimen type collected, on label, those samples can be then loaded onto the Panther rack. And of course, the Panther is random access, and you can load a vaginal sample next to a urine sample, next to an endocervical sample. You don't have to worry about batching. You don't have to, really run specific sets based on specimen type. They can be loaded right next to each other. The other nice part about the Optima collection devices, of course, is that penetrable cap. And so, of course, the pipette tip in the Panther comes through and pokes through that penetrable cap for sampling on the instrument. And it eliminates some of those non-value added steps like uncapping and recapping of the tube. And so these certainly have been a great convenience for many laboratories and, of course, the physicians that collect the samples. One particular sample type that I think stands out and a lot of laboratories are very interested in is the Optima multi-test swab. Again, it's that orange stickered swab. And that's because you have the ability to detect up to 7 different infections or disease states from a single collection. The Panther itself can pull 4 aliquots. And so you might be wondering how that works out. Of course, some of the assays are multiplexed. So one aliquot is chlamydia and gonorrhea. One possible aliquot could be bacterial vaginosis. One possible aliquot could be Candida group, Candida glabrata, and trick. Of course, we offer a standalone trick as well. And then finally, optima mycoplasma genitalium. So that's the way you can get 4 different aliquots from the same specimen. And so for me as a former laboratorian, this is a huge benefit. I remember I spent so much of my time calling physicians and saying, gosh, I really wish we had the right collection, but we don't. They would get frustrated, we would get frustrated, and the patient obviously would get very frustrated. They would either, have to come in, or maybe we could cobble something together. But if you think about things like chlamydia, gonorrhea, and now MGen, the serious impacts of an untreated infection, it certainly makes us concerned if those specimens aren't being tested, if it gets ignored or forgotten. And so we wanted to ensure that a laboratory has the opportunity to run these samples and run these tests and ultimately identify these patients so they can be treated downstream with minimal interruption. And so lastly, to wrap up, I just want to remind everybody here today that MGen testing has been recommended for all patients with recurrent cervicitis, urethritis, and can be considered in cases of pelvic inflammatory disease. And these are from the latest CDC guidelines. It's important to test for and target the right infection, and so you can ultimately treat the right infection. As Dr. Shutter mentioned, antimicrobial resistance is becoming a serious issue, and so certainly we want to make sure that we're targeting the right organism to provide the right treatment. Nucleic acid amplification testing is the CDC recommended method for detection for MGen. And with NAT testing, you have different ways to test to amplify nucleic acids and potentially different targets. But ultimately, it's ribosomal rRNA that improves sensitivity compared to DNA-based tests. And ribosomal RNA-based tests actually have been shown to identify up to 40% of infections that otherwise wouldn't have been identified in DNA-based tests. And with that, I'm going to turn it over for questions.
Thank you so much, Dr. Maxwell-Stropes, and thank you also so much to Dr. Shutter for those great informative presentations. We have a lot of time at the end here for questions, and we've actually already had a few come into the queue. So Dr. Shutter, if you want to turn your camera on and we can all kind of be here, and Dr. Maxwell-Stropes, you can actually stop sharing your screen so we can all see everybody up close. Perfect. So I think Dr. Maxwell-Stropes, this first one is for you. They say, we collect urines on both male and females when testing for MGen. Is a swab better for collection in females?
Yeah, that's a great question. So in our package insert, this is addressed. So swab is the preferred specimen type. We've seen this with chlamydia as well. Swab is preferred to urine as well. But it is an option. Urine is an option for testing because there's a lot of convenience with that urine as well. But we think that the load of MGen is lower, and so a direct swab is probably going to detect more.
Okay. All right, Dr. Shutter, this one is for you. Someone is asking, has ACOG weighed in on MGen testing?
So no, is a short answer. They updated the recommendations with regards to STI recommendations in 2014 and have not updated it since. And they did not mention it in the 2014 guidelines. Now that the new CDC guidelines in 2021 have been published, I would hope that in their next iteration, which shouldn't be coming along too far in the future, they will address it.
Okay. And then this next question, is this MGen test screening testing?
So the recommendations for MGen are for patients with recurrent cervicitis, for women with recurrent cervicitis, and can be considered in pelvic inflammatory disease, and for males with urethritis. So the CDC has weighed in on specific populations that they are interested in having, or they're recommending to be tested.
Okay.
And at this time, screening is not recommended, just to point that out from the CDC guidelines.
Okay. Dr. Stropes, I think we'll stick with you here for this one. Is ThinPrep an approved specimen type, and what is the performance of it?
That's a great question. No, it is not. As you saw from our slide about clinical trials, it was not one of those that was included in the clinical trials. So we don't know necessarily the performance of it. But one thing I would also mention too, just sort of like urine, what we talked about before, we think that direct swabbing is probably the best route for detection. And so ThinPrep would further remove that patient specimen from direct swabbing. You put in the ThinPrep, and that ThinPrep would have to be transferred. And so again, the performance hasn't been established, but it likely is not an optimal specimen based on the fact that direct swabbing is probably better.
Okay. If all 4 aliquots were used from one sample, would it be possible to repeat the sample for any positives?
On label no and no, and I don't know of any. We have four pools, and after that, this specimen is exhausted. If there are other tests that are non-hologic tests, I can't speak to that. But as far as hologic testing, it's limited at four aliquots.
Okay. And then Dr. Shutter, I think this one for you, we've actually gotten a couple of questions about the recommendation for partner treatment with MGen.
Yeah, so the CDC has stated that sex partners of patients with symptomatic MGen infection can be tested. And for those with a positive test, to possibly reduce the risk of reinfection, because certainly if you don't treat the partner, then that partner can then reinfect your primary female patient, that you can treat them. If testing is not possible, then it is acceptable to give the antimicrobial regimen you're giving to your female patient to the male patient to treat them as well.
Okay. Dr. Stropes, probably this one for you. Someone is asking, does Hologic offer an MGen antimicrobial resistant test?
Yeah, that's a great question. So right now there are no FDA cleared assays on the market for MGen AMR. With the CDC talking about resistance testing, certainly there are considerations by us and others for potentially something down the line, but at the moment, we do not have anything, we don't offer anything for AMR.
Okay. And then Dr. Maxwell-Stropes, probably continuing here because these seem specific to Hologic, is MGen available on the Tigris system?
Nope, it is just available on the Panther system. And of course, the Panther system has a very wide variety of menu options that also aren't available on the Tigris system.
Okay. Lots of great questions.
I actually do see a question in the Q&A area that I'd like to answer. It was from an anonymous attendee. I'll read the question. Can you read the question, actually, the one that starts with "there clearly seems"?
Sure. Yeah, absolutely. There clearly seems to be a need to test for MGen and is backed with the current guidelines. However, even in the face of the data you've presented, there seems to be a push for testing for ureaplasma and other mycoplasma species. What are your thoughts on handling this type of request that seems based on anecdotal correlation, given there appears to be no formal recommendation to test for them?
So this is an extremely challenging subject, and one of the reasons our largest laboratory we don't do MGen testing is because it was very difficult for me to convince the people that anecdotally felt like these organisms were actual pathogens, no matter how many times I showed them the data that they're actually not. And so, we would have liked to have brought MGen into our largest laboratory, but we could not because I could not convince enough of the providers to abandon the non-recommended organisms to test. Luckily, in the market I mentioned that we do it routinely on our vaginitis vaginosis panel, the main doctor that was doing a majority of the MGen testing or mycoplasma ureaplasma testing, when I showed him the data, he's like, wow, I didn't know that. Yeah, let's just do MGen. And then we used him and myself to educate the rest of the group about why we don't need any of the other ones. And so that was it's a challenging subject. The unique situation I am in is I am constantly in contact with the group because I am actually, a part of the group. I'm not an independent reference laboratory where when you get an order, you just do it. There are, and I'm not a fan, and I don't bring in any test that I don't feel has any clinical significance to it. And we could have, developed some LDTs around those other three organisms, and then combine that with our MGen assay from Hologic. But again, if there's no data to support the testing of these, plus if you then try to treat them, if they're positive, you're promoting additional antibiotic resistance. I didn't want to be part of the problem. So, the fight still goes on. And I say fight, I mean more like discussion of trying to convince some of these providers that all they need is MGen. And I haven't given up, but it really depends on your practice environment. If you're in a reference laboratory, and they say they want the test, sometimes there's nothing you can do about it. Luckily, in our practice, part of my role is provider education, and I do talks all around the country in our different markets about these sorts of things. And I'm slowly but surely convincing our other markets that they don't need anything but MGen, and I'm hoping in the future we will be able to move over to that. But again, it can be a challenging conversation, but my advice is just hit them with data and CDC guidelines. The things we talked about today come straight from the CDC or international organizations that have a lot of clout within the world about what they think is the right thing to do. So, having those conversations in a very non-confrontational type of environment, more like a collegial environment, is my recommendation. There are some doctors that have been doing this for a long time and just feel like anecdotally those organisms are pathogens, and no matter what you say to them and what you show to them, they're not going to listen or agree with you. So that's a constant challenge. So that's my recommendation, is just hit them with evidence-based literature. And if they're not going to listen to that, then there's really not much more you can do, unfortunately.
Dr. Shutter, I'm going to stick with you here. We've gotten a question about insurance coverage. So is MGen covered by insurance, or any tips on getting it covered?
Well, I can tell you, the one thing I can tell you is that there is a brand new code that was effective January 1st of 2020. The code is 87563. I think it goes beyond the scope of this talk to start talking about medical policies and coverage depending on, because also all insurance companies have different medical policies associated with every type of amplified NAT testing. And it's not, talking about things in a universal setting is not easy because different companies have different ideas on what is recommended and what is paid for. So I think it's sort of beyond the scope to talk about that. Plus, you have to also make sure whenever you do a symptomatic panel looking for organisms in a symptomatic environment, that you make sure you attach the symptomatic ICD code. That's the one thing I can tell you is that, a lot of insurance companies are not going to pay for, testing for asymptomatic screening of organisms we know are only clinically relevant when there are symptoms present. BV being a great example. Of those insurance companies that pay for BV, they are requiring you to add an ICD code that is symptoms, not pregnancy or screening for STDs. Because again, also BV is not generally considered an STD. And so, that's again, a little bit beyond the scope of, I think, what this talk goes through. But medical policy management is extremely difficult. I unfortunately have a lot more understanding of that than most pathologists do because of how I have to develop and run these laboratories. But we could probably spend hours talking about that and the different insurance companies and their policies. So I'm just going to end it on the fact that there is a specific code for MGen. And then my advice would be to look at medical policies and the ICD codes that go with them.
Okay. I think we've probably got time for maybe 2 more questions. So Dr. Maxwell-Stropes, is MGen a reportable disease?
No, it's not. There are certain criteria that have to be met for an organism to be considered reportable. And while there's accumulating evidence for MGen's association with disease, we're just not quite there yet for it to be a reportable disease.
Okay. All right. And then I think our last question, can patients self-collect MGen at home? And is self-collect the same as home collect?
That's a great question. Something certainly because of the pandemic has been a topic of interest for people who aren't visiting their physicians. So the self-collect is meant to be collected within a clinical setting. The home is unfortunately not a clinical setting, so this was not intended for home use. That would be considered off-label use of collection.
Okay. All right. Well, that is all the time we have today. So Dr. Maxwell-Stropes and Dr. Shutter, thank you so much for joining us and for your insights. And for those attending today's webinar, once the recording becomes available, Hologic will be able to share that. And with that, we hope everybody has a great rest of their afternoon. Thank you so much for joining us.